If you've ever thought about it, the whole process of being born is wild. I mean, there's the whole just getting out business, there's a whole lot of risk there. But then you have to start adapting to the outside world. You got to learn how to breathe the air. You have to learn how to use your mouth for the first time. You're doing your best to just survive these first couple of days. And here's one of the things I didn't know. If a key hormone, if insulin misses its switch in those first couple of days and it starts flooding into a newborn's body, that's where you can really run into trouble. And that's where we run into pediatric endocrinologist Dr. Daphne Yau. She's our guest today on Researchers Under the Scope. Hi, I'm your host, Jen Cannell, and we are recording this episode of Researchers Under the Scope on Monday. It's February the 19th, 2024, and today it's Dr. Daphne Yau who's our guest. She's an assistant professor of pediatrics at the U of S College of Medicine, and she's a pediatric endocrinologist. And today, she's joining us online just to talk about her work in hypoglycemia. So good morning, Daphne, and welcome to Researchers Under the Scope.
Hi, good morning, Jen. It's lovely to be here.
Well, and I'm wondering what is going on for newborns in those first couple, the hours and just the days or two right after they're born. What is happening with adapting to eating and their glucose, their blood sugar levels?
So that's a really, really good question. And I think that's a really great place to start. So before a baby is born, they're getting kind of a continuous glucose or sugar supply from their mom in essence. And then once they're born, they're sort of cut off from that supply, right? And so what happens is initially their blood sugars are going to be lower than, and that's a normal thing, lower than yours or mine or older babies. But then after a few days, they normally those blood sugars will rise and be not really different from, significantly different from older infants and children and adults.
Okay.
Now, the problem is if those blood sugars stay low, for example, if their body isn't able to sort of adapt to that, for example, if it's because their body's producing too much insulin, then they can have low blood sugar, they can have hypoglycemia, and those symptoms are going to sort of run the spectrum. They can be pretty what we call mild or non-specific, and it's kind of hard to distinguish what the issue is, whether it's low blood sugar or they're getting sick with something, or like they can be not feeding as well. They can be like less awake, less alert. They might be a little bit jittery, sometimes a bit irritable. At the other end of the spectrum, you can have a baby who's just really not responsive, maybe even having a seizure because the blood sugar is too low and it's not feeding their brain, and so they're having a hypoglycemic seizure.
Oh, so that's what the blood sugars are supposed to be doing. They're feeding your brain, they're cueing you, okay, let's grow.
Exactly.
And
Exactly.
when you miss that,
Yeah.
what, how often does that happen?
So, hypoglycemia or low blood sugars are very common in newborns. In terms of ones that become problematic that need maybe treatment, investigations, or treatment of some sort, it can be as high as 1 in 1,200. The more sort of rarer, persistent ones, due to a gene problem or gene mutation, probably more like 1 in 30,000, 1 in 50,000, depending on what papers you read and what population you're talking about. Yeah.
What are the effects if you don't have insulin hitting at the right time? What can happen to a baby?
Yeah. So your brain can't really store much in the way of glucose, and it can't make it on its own the way some other tissues and organs in the body can do that. And what's even more critical in infants and in young children is that their brain accounts for, you think about how big a baby's head is compared to the rest of their body. So their brain actually accounts for a lot of that glucose use in the body compared to other tissues like the muscles, the heart, et cetera, et cetera. So their brain uses most of that glucose. So that's why it's so critical in that period that they get a steady supply or enough glucose to the brain. And so if they don't, it really depends on kind of how long their brain has gone without enough glucose and how low those blood sugars are. And then long term, that can have, impacts, potentially, permanent brain injury, brain damage, unfortunately. So it could be quite severe where, the child is very incapacitated, maybe things like cerebral palsy, that sort of picture, visual impairment. But it can be also more like developmental delays, later on, learning difficulties. There's certainly increasing evidence that there's things like increase in autism spectrum disorder, ADHD. Potentially, there's those associations as well. Um,
All the things that happen to your brain.
yeah, exactly, right? And some of those really may not be evident. If you test a child who's had hypoglycemia when they're 2 or 4, you may not actually pick up on this maybe later on when they're in school and they're struggling, and that's when you kind of pick up those learning issues and challenges later on.
Oof.
But so it's quite a gamut of things, and it does blood sugars are a piece of that, a big piece of that. But I think what's tricky to tease out is that sometimes these infants also there might be issues with oxygenation and other things, infection. Some of them are also born premature as well. So it's also trying to tease out the contribution of all those factors in terms of the impacts on the developing brain and their outcomes down the road.
Oof. I can see how there are so many threads to pull on this, but for you, I kind of want to go back to the start of your journey with this, where,
Sure.
like, at what point growing up did you realize, yeah, I think I want to do medicine, or I think I want to know more about healing people? Like, where did this come from?
Yeah, no, that's it's hard to pinpoint it down to a single moment or single experience. I mean, I grew up in a very, I guess, medical household. My late father was a family doctor and my mom is a retired pharmacist. So there's a lot of
Oh,
medical talk. Yeah, exactly. And actually one of my late aunts, my mom's sister, who I was quite close to too, she was also a physician as well. So I think there was a lot of medical influence, and I think I sort of almost took it for granted that, yeah, I'll probably do something in medicine, probably be a doctor. But I think it really wasn't until like later on, you sort of think about what is really involved in terms of medicine and becoming a doctor and even just getting into medical school. And I did actually before medical school do a little bit of I did a master's and it was in laboratory research, and it was actually in
oh,
looking at a mouse model of type 2 diabetes. So that was kind of sparked some interest in insulin, what we would say beta cell physiology. So that's the part of the pancreas that makes insulin. So it was fascinating. It also made me realize that maybe pure research, especially maybe a laboratory research, wasn't quite for me, but it was a great opportunity, learning opportunity. So I think that was maybe the combination of those, was what's sort of pushed me towards medicine.
when it comes to just having blood sugars that are just you can't bring them up enough when insulin's just not doing its thing right, it's not hitting the switch. Would you say there was a TSN turning point?
Yeah, I mean, I would say it was actually there was a patient that I cared for during my pediatrics residency who turned out to have hyperinsulinism, but it was like this baby who I was actually on my neonatal ICU rotation, and yeah, it was like one of those 1 in 30,000, 1 in 50,000 really severe cases where where the blood sugars were horrendously low right from the start. We were sort of pouring lots of glucose or dextrose into this little one, trying to get the blood sugars up, and needing quite a lot to sort of stabilize those blood sugars and try to figure out what was going on. And it turned out that this child had a gene mutation that actually was the culprit for the issues with the blood sugars kind of early on. Yeah.
If you remember back at that point in your life, like what really stood out about caring for this little one?
um on one hand, hypoglycemia treatment isn't complex in the sense that you need to just give them more sugar to kind of counteract the effects of that, right? So, I mean, conceptually, it's not challenging, but then, yeah, it's like, how do you do that when babies are really, and this baby was born a little bit early too, you have to be careful about not giving them too much fluids. And so, how do you manage to get enough sugar in them while you're trying to balance not giving them fluids and also, making sure that you have enough like what we call IV access and kind of getting a central line in. And obviously time is of the essence because you really want to minimize the time or that they're low. So it was kind of that multidisciplinary approach, working closely with the neonatal nurses who are excellent and have all sorts of, expertise and everything. And then working with the endocrinologist as well at that time too. And just both the kind of the management right in the moment to try to stabilize things, but also thinking about sort of long term, what do we need to do and what's causing this. And actually what was interesting in particular about this case was the gene that was responsible is also a gene that can cause a rare form of diabetes.
Oh,
Yeah, there's type 2 and type 1 diabetes, and that's most of it, but then there are some rare sort of gene changes that there was a family history in the mom and the grandmother of diabetes, and they were told, well, it's type 2, and then they kind of subsequent to this had actually realized that it was actually this rarer form of diabetes that can be sort of managed a little bit differently. Plus, it has obviously implications because there is a risk of hypoglycemia in babies who have this mutation. So as
oof.
well,
So there
yeah.
is a genetic link, and that sounds like where you started really pursuing more the endocrinology end of this, isn't it?
Yeah, exactly. I think that's really what pushed me. I mean, I think I'd already thought I'd probably wanted to do I liked endocrinology and I liked the pediatric side maybe more so than the adults. I don't have anything against adults, but it was just more that that was maybe a little bit more my thing, and so that was seemed to be a sort of a nice way to combine those two interests. In that, I think in being involved in that case really sort of solidified that that was my interest, and particularly in problems with hyperglycemia.
From there, I know that you've arrived at the University of Saskatchewan's College of Medicine. That would be about 5 years ago now.
Yeah.
And these days, this far in, what does your research look like today?
Yeah, there's hypoglycemia research, but there's actually so a lot of the genes and those pathways that are involved in too much insulin production, you can sort of imagine that here we do see quite a lot of children and adolescents with diabetes. And so actually one of the big projects that I'm involved in is actually not related to hypoglycemia, but actually more to diabetes screening and education. So newborns when they're born they have that blood spot, that heel prick test that screens for a lot of things.
Yeah.
You can actually test for a lot of things on that blood spot card. So one of the things you can do is something called a hemoglobin A1C, which is one of the ways we both test, screen for, as well as monitor diabetes.
Hmm.
And so this project carried out by my colleague, Dr. Mark Inman, looked at using this in the pediatric population as opposed to going to a lab to do kind of an A1C. Could someone at home kind of, prick their finger, put some, few drops of blood on this card and have their A1C measured that way, as opposed to having to go to the lab. And essentially, there's a paper that's, yeah, I think it's just been published, or it's about to be published in the Canadian Journal of Diabetes, which shows that it's a good test. Like it compares favorably, like just as well as going to the lab to do what we call a venous A1C or kind of, that sort of thing. So kind of branching off from that and thought was, well, okay, if we can use it to monitor in individuals who have diabetes, could we use it as a screening tool? Because one of the, I would say, barriers is laboratory access, right? So not, especially given
Oh,
the province that we live in or in Canada, where, if you're not in an urban setting, and even then there can be barriers to get to a lab, especially, highlighted during the pandemic and everything. So this project is really to look at, can we use that blood spot to screen for type 2 diabetes in actually indigenous youth who live in remote and rural areas of the province, and how is that working as a screening tool? And also we paired it with education around type 2 diabetes as well.
so how do you test whether this will work? Like, is there a little strip you can send out? Are there little samples that like nurses in sort of remote communities can use?
Yeah. Essentially, we've gone to a community and we've sort of held kind of an event at one of the schools, done the blood spot testing with the students as well. So we've sort of used it that way.
And the results are favorable compared to like if they were in the city getting lab work done?
Yeah, I mean, it's still in progress. We haven't, but I think it certainly is. We're getting feedback from the students and from the staff, so that's still sort of pending in terms of that. But just in terms of the ease, as opposed to having to go to the lab if you're living, a couple hours away, or if you're on reserve and maybe your health center or your nursing station, nobody can take that blood, or and then actually, even if there's someone to be able to collect that sample, how do you get it to the lab where it's going to be processed, right? So,
Exactly.
right?
But that
Yeah.
does sound
So
like for remote and indigenous communities, we don't want them left in the dark. We don't want these diseases going undiagnosed for too long. That's really the trouble, hey?
yeah, if we look at risk factors, you know, if there's a family history and certain, ethnicities are more at risk, right? And so I think, unfortunately, a lot of our indigenous youth really fit that category. How do we make it more accessible and easier to screen? At least remove one of those barriers. There's many, and it's very, I think, layered and complex. But at least sort of seeing, is this even a viable option for some people?
And I know in another branch of your research, looking back at hypoglycemia and sort of the rare disease side of this, I understand you've been involved also with researchers in the United Kingdom, right?
Yeah, yeah, no, exactly. Yeah, so before I moved here, I was actually working in the UK doing sort of some post-fellowship work in hyperinsulinism in Manchester. But there, the two major centers are Manchester with Liverpool, and then Great Ormond Street in London. So sort of, built up collaborations with both groups. And yeah, one study, it was really looking at the first line treatment for individuals who have hyperinsulinism, endogenous hyperinsulinism, or insulin where it's their own body producing too much insulin, is a medication called diazoxide. And it's actually quite an old medication. It's the only FDA approved medication at this moment. It's the nice thing is it's an oral medication, because the other ones are injection, but it does come with some side effects. And one of the things that this study looked at was, there's sort of a dose range that's typically used. Can we get away with a lower dose in infants, especially infants where we know it's probably the type of hyperinsulinism that's going to eventually, get better in the first weeks to months of life. And so they don't need to be on such a high dose, and therefore hopefully being as effective, but reducing potentially the risk of side effects.
Especially over the next, say, 15 or 20 years, what would you like to see developing in this area in terms of treatments and things that will work better for these really small patients?
Yeah, that's a tricky question to answer. I mean, I think going back to that treatment piece, like that is a first line medication. Yes, it can be given by mouth. The downside is that there are side effects. Some of them can be quite, like, they're not common, but they can be quite significant. Things like what we call pulmonary hypertension. So and the other thing is that it doesn't work for all types of hyperinsulinism.
Uh,
And so that's when you end up having to step up to, injection medications. And if that doesn't work, then you're sort of looking at other ways to keep the blood sugars stable. And sometimes that means, or keep the blood sugars in normal range. And that sometimes means having surgery on the pancreas as
ooh,
well. So I think looking at treatments, and I know there's a few treatments in development, including one that the U of S in Saskatoon, hopefully will be, a site for one of the clinical trial, but we're still working through some of the process of becoming a site there, but for that study. But I think really treatments that are going to be effective and, that have a favorable, what we call side effect profile. So really safety. Because, even if it works, if there's a risk of harm to the patient, then you certainly, we don't want to recommend that. So I think better treatments that work and treatments that are safe, I think, is a big need for patients with congenital hyperinsulinism. So that's a big one. And then I think the other thing would be kind of talking about the whole blood sugar changes that happen in the early period after a baby is born. I think there's still a lot of debate as to what is like what are normal blood sugars in that period. And I think we've got a lot more information. There's a lot of great research coming out of various centers, including, for example, New Zealand. But I think it's then also sort of kind of try to figure out, all right, are those levels the levels that we should be using for someone who is at risk? Do they actually maybe need to have higher levels? Like, are those really the right treatment goals, for patients who have either a suspected or known problem with their blood sugars?
right.
And at what blood sugar levels should we be aiming for, that's going to sort of minimize the risk of long-term impacts on the brain? So I think having, I guess, better ideas and better, I think, which the prospective study. So going forward, sort of seeing what are the levels we really should be targeting to kind of minimize long term potential for long term harms.
Oh, and that's so tricky because right now it sounds like we're comparing these children to completely typical children, completely got everything right children, whereas there should be a range, right? And it's where in that range
Mhm.
should this kid be scoring?
Yeah, it's also tricky to figure out, okay, was this just the blood sugars? Was it all the other things going on in that time frame, right? So how do you tease out the impact of just the blood sugars from everything else? It's an ongoing area of a lot of investigation and debate, but I think that's one thing that would be nice to have, increase better data information, sort of better clarity on what are safe levels that we should be kind of aiming for in babies.
Yeah. Well, I wish you luck with it. Thank you so much for talking to us here on the podcast.
For sure. No, thank you so much for having me.
Dr. Daphne Yau is a pediatric endocrinologist based at the Jim Pattison Children's Hospital here in Saskatoon. She joined the University of Saskatchewan's College of Medicine 5 years ago, and she's an assistant professor of pediatrics. You can see more of her work on hypoglycemia at medicine.usask.ca. Researchers Under the Scope is a presentation of the Office of the Vice Dean of Research at the U of S College of Medicine. We record this podcast on Treaty 6 territory, and we pay our respect to the Métis and First Nations ancestors of this place, and we reaffirm our relationship with one another. This is also the part where I say thank you for sharing your ears with us and for tuning in. I'm your host, Jen Cannell, and to follow Researchers Under the Scope, just go find those little dots in the corner, hit follow, tell a friend about the podcast. That way, no one misses a Researcher Under the Scope.